Good afternoon, everyone, and welcome to the Social Determinants of Health webinar by healthevidence.ca. I am Maureen Dobbins, and I'm very happy to be with you today to talk about social determinants of health. Just a little bit of housekeeping. So some of you have already heard a few times from Diva some housekeeping. I'll just go over a few things one more time. So in order to interact and communicate with us, please use the chat and the question and answer windows on the right-hand side panel, and some of you have already posed a few questions to us. In order to answer your questions during the question and answer section of the webinar, please raise your hand by clicking the hand icon in the participants panel on the right-hand side. The hand icon will appear beside your name in the participants panel. Clicking the hand again will lower the hand and removes it from the attendee list. You can also use, and also if we, to speak with us, we just request that you are using a headset. In the past, it's just very difficult to hear if someone wants to speak without using a headset. You can also use the feedback icon, and we'll be checking in with you a few times during the webinar to see how things are going. And the feedback icon, again, it is in the participants panel about halfway down. Dive is just showing you where that is. It's a little check mark with circle, and in there you can answer things like yes or no. So if I'll just ask right now, can everyone hear okay? You can click on that feedback and just let me know yes or no if you're hearing everything all right. And then also, just while that's happening, we'll be conducting a few polling questions during the webinar just to gather a little bit of information and seek your feedback as we go. So it looks like everything is okay. So the first thing I just would like to know is where people are from. So can you let us know with this polling question where you are from by your province, country, or even continent. So there's just a slight delay in that being posted. It should be coming up momentarily, and if you can just respond for us, and I'll let you know what we're seeing as that data pops up. I have the pleasure of actually seeing things happening in real time. We'll post those for you after the fact. Here comes the data now. And actually, just while that's happening, this is the second webinar on social determinants of health that we're holding. We held the first one a couple of weeks ago, and the demand was really very high, beyond what we could accommodate for just one session. And that's how we ended up with today's session, wanting to make sure that we had enough spots for everyone that was interested, that we were able to offer another one today. I'm very glad that you were able to join us if you couldn't join the first time. So it is looking like Ontario. The majority of people on the line with us today are from Ontario. We do have, looks like, one person from the United States, so welcome, and then some people from BC, Alberta, Saskatchewan, two people from Nova Scotia, and another person from Newfoundland. So welcome, everyone. So this is the Health Evidence team, made up of a group of people led by myself, Cara DeCorby, Diva Trillis, who's the lead on this particular project, the Meetings, Dissemination, and Planning Grant. Lori Greco, some of you will know, who is a knowledge broker currently working with health evidence and interacting with public health decision makers. Heather Husson is the manager of health evidence. Robin Trainer is a research coordinator, and Lindsay McRae also does a lot of work in keeping the healthevidence.ca website updated. So just before we get into the topic of social determinants of health, I just wanted to talk briefly about healthevidence.ca. So Health Evidence is an online registry that you can search. It's freely available, and you search to inform decision making. This website was actually launched back in 2005 after we had heard from many public health decision makers across the country that a barrier to using evidence in decision making was difficulty in actually finding, accessing, and retrieving the evidence. So we've been working hard over several years to facilitate access of the public health evidence. So just want to do one other poll, and prior to today, who had heard of health evidence prior to today's webinar? So that's just coming up as a yes-no question. And it looks like the majority of you had, so that makes me, of course, very, very happy to hear that, but also really happy for those of you that hadn't heard of it to have you on the line to hear more about it today. So health evidence is a one-stop shop. If you are looking for research information about the effectiveness of public health interventions, then health evidence is one of the places that you can come to find that. We put all of that evidence in one place. We also appraise the methodological quality of those systematic reviews so that you can hear from a credible source whether or not that evidence is good enough to use in practice. And then just briefly, what are systematic reviews? So a systematic review is a process for combining the results of all the evidence available that's answering a particular question. And what makes a systematic review different from other types of literature reviews that are out there is that a very explicit, rigorous, systematic process is used as one goes from defining a question, searching for the evidence, deciding what is relevant to the question, appraising the quality of the evidence, and then extracting that data and synthesizing and interpreting it. So just a little bit more about why health evidence would be good to use. So definitely we have heard from users over the years it does save time in terms of not having to go and do the database searches yourself. At any given time, health evidence is only about 4 months behind in terms of the published literature. So for example, if you were on the site today, we would have everything that's been published at that review level evaluating public health up to about 4 months ago. So it's relevant. Everything in health evidence is related to public health practice, so the evaluation of public health interventions. We, of course, want to use a very transparent process, so how we go about searching for the evidence, how we decide which reviews make it into the database, how we critically appraise our assessments of those critical appraisals, and how we assign keywords to every review. All of the tools that we use for those processes are available on health evidence so that you can actually see how we do that. We also provide additional support. So we know that evidence-informed decision-making is complex, challenging work, and that just having access to the best available research evidence doesn't necessarily make it all that much easier to use in practice. And so we've also been, over the years, evaluating different types of knowledge translation strategies, working with public health decision makers to help them use the evidence. And as that work has evolved, we've also developed some tools that would help decision makers in various stages of the EIDM process, and those are also available on the site. And first and foremost, we've asked public health decision makers across the country at all levels in public health what kinds of functions they would like health evidence to do, what would make it easy for them to use health evidence, and we've done our best to create a site that responds to those needs and preferences. And certainly there's a feedback loop on health evidence. I always say that health evidence is a work in progress. We're always tweaking it, always trying to make it better, and always happy to hear your comments and thoughts on ways we can continually improve it. So just now, that's the end of our commercial. Maybe it was, I'll have to get better at making shorter commercials for health evidence. So on to what you're all here today to talk about, and that's about this webinar being a way to discuss the findings of a review on one aspect of social determinants of health. And this has been made possible by a CIHR grant that we received that falls under the Meetings, Planning, and Dissemination Grant, whereby we proposed to summarize the findings of some high-quality reviews that have been funded by CIHR and then to promote the dissemination of those findings amongst the public health community in Canada. So in particular, when we originally searched for CIHR-funded reviews in the last few years, we found the review by Wang, which was Interventions to Improve the Health of the Homeless, a systematic review. And that was originally what we were going to be doing the webinar, but we're very happy to see that just earlier this year in 2011, an update to this review was published, and so the webinar today, the content of the webinar, will focus on the results of this updated review called The Effectiveness of Interventions to Improve the Health and Housing Status of Homeless People, a rapid systematic review. So I'm just going to ask another question now, another polling question that asks, do you know the difference between a systematic review and a rapid review? So if you can answer yes, no to that. So I'm just seeing the data coming up here in front of me now. It's actually a pretty close tie right now. There's actually a few more people saying they know, they do not know the difference. But it's a fairly close race, so it's almost 50-50 in terms of who knows the difference between it. And so why don't I just talk about that for a few moments. So if I just start with perhaps what a systematic review is, and as I was just saying, a systematic review is a very comprehensive, explicit process that usually involves two people at all stages independently assessing whether or not studies are relevant to the question, then also assessing those studies for methodological quality as well as data extraction. You would do an exhaustive search to find all of the evidence in the published and unpublished domain that answer that question. And generally, systematic reviews take anywhere from 6 months to a year to complete. They are something that are very comprehensive. We can usually feel some confidence in those results as a result of following that rigorous process. But in terms of being able to respond quickly to the needs of decision makers, they don't necessarily fit that bill. And so we have a new emerging technology now called rapid reviews. And this is an attempt to be able to answer decision makers' questions in a much more, in a quicker fashion so that they can use those results when they need them. And many people are becoming involved in rapid reviews, research groups, and for example, the one we're discussing today, which was completed by the Effective Public Health Practice Project. So various types of research groups, systematic review groups are getting involved in in rapid reviews, as well as public health departments themselves. So a number of health departments I've become aware of in the last few years are moving into doing these. So a rapid review is, again, a literature review that pares down some of the processes of a systematic review so that it can be done faster, but while still trying to maintain a rigorous process. So it might be that the not as an exhaustive search for the literature happens. For example, you might just search for English studies as opposed to any language study. In this particular review for today, as opposed to having two independent raters review all of the studies for all the different components, generally two reviewers assessed whether or not the studies were relevant for the first 10%. They looked at their consensus. They had a high consensus, and then moving forward, just one person then did all of that reviewing for the article. In this particular rapid review as well, those studies that were judged to be of weak methodological quality were then removed from further analysis, and therefore no data was extracted on those studies, which is different from the way systematic reviews would traditionally be done, which is now currently supported by the Cochrane collaboration, which is all of the studies that answer a particular question should remain in the review even if the methods aren't very strong, but that you would just make sure you discuss that in your critique of the literature. So in this particular rapid review, any weak quality studies were excluded. And then finally, what's different about this rapid review than a systematic review is that there was no additional contact made with the authors of the primary studies for additional information. So again, with a systematic review, many times if there's important data missing out of the write-up of a study, then you would contact the author to get that additional information. So in a very a bit of a nutshell, there is what the differences are between those two different types of reviews. So I'll just take a moment now and ask if there are any questions that anyone has that I can answer at this time. So I don't see any questions, so I'm actually now going to just give some feedback to you, some information you've provided. So just before the webinar started, we asked you two questions. The first one was, what has been your experience in finding or using evidence related to the determinants of health? So the comments that you wrote in to us were, often interventions on the social determinants of health do not include measurement of health outcomes in the evaluation framework. We've also heard what you said is mostly you use Google but have had some exposure through conferences. The topic of social determinants is not directly related to my clinical work. It's difficult to find strong evidence, was said by someone else, even with qualitative study designs for social determinants of health. We also asked, how do you use research evidence to inform your practice? And here are some of the comments that you made to us. So someone has said, primarily to engage and inform policy researchers and decision makers outside the health sector on social determinants of health. Another comment was, look to evidence to define what might be the strongest strategy to resource for a given outcome. Another comment is, used journal articles, but I'm very interested in more grassroots styles of evaluation, reflective practice as evidence. Another comment was, use evidence to develop policy. And then finally, I work with best practices in health promotion, and I'm constantly looking for evidence to support nominated practices. So thank you for providing that information, and it does sound like a nice variety of different types of exposures and experiences and use of research evidence. I have a question here right now, which says, where on the hierarchy of evidence does a rapid review fall? Is it considered better than or the same as a systematic review? So thank you. That's an excellent question. And you know, to be very honest, I wouldn't say I've actually really thought about where it should be on the pyramid. So the first question, where would it go on the pyramid, likely would still go at that synthesis level. So it's not a primary study. A rapid review is still trying to summarize the results of multiple studies. So it would still belong at the summaries level of the pyramid. Would it be considered better than or the same as a systematic review? My opinion is that the answer to that would have to be no, even though I guess there's some caveats you could put in there. A systematic review, when done well, and not all systematic reviews are done well, so let me just say that, but when a systematic review has been done very rigorously and has an explicit process that's been followed, that starts with that defined question, a priori identification of inclusion and exclusion criteria, and a comprehensive search that will find all of the available literature, the published, the non-published, in English, not in English, then a rigorous approach for assessing the methodological quality of the studies, the synthesis of those studies and interpretation and writing that up, and using two people to independently review all of that and develop consensus. It's in doing that kind of a process that one can put a great deal of confidence into the findings of that review, because different biases that can be introduced along the way are really controlled for in that type of an environment. A rapid review in omitting some of those steps does allow some of that bias to sneak into the review. So for example, not looking for only using, for example, the English literature means that literature published in other languages where at this point we have data that would suggest if English is not your first language and you did a study that found a very significant positive effect, you would be very motivated to publish that in an English journal. If you did not find a significant effect, then you would be more likely to publish that in your own language. Similarly, we know that there's a bias in just having the published literature. So journal editors are very interested in publishing newsworthy studies, which usually are telling us that something worked or something harmed someone, and that is statistically significant. So if we only use the published literature, then we could be missing a whole series of studies that actually show that an intervention doesn't affect. So some of those processes that are omitted in a rapid review would leave us with some worry about how confident we can be in the results. But at the same point, what we can think about here is the evidence, we always need to ask ourselves, is the evidence good enough to inform my practice? And if a rapid review does the other parts of the review well, in terms of using the 2 independent reviewers and using a good strategy for assessing the quality of the primary studies, has in a number of those processes, then in many instances, particularly for the purposes of decision makers who need something faster to inform their decision making, then this is a good way to go. Okay, so thank you for that question. So moving on to just talk a little bit now about summary statements. I want to just start with asking you who has heard of PICO before, so P-I-C-O. So the data is just coming in now, again, and looks like the yeses are winning out this time, even though it's close to 50-50 in terms of yes and no. So just as those final few of you, as your data comes in. Yeah, so our final answer there is it's about 50-50. Just a few more of you have heard of PICO. So just very quickly, PICO stands for Population Intervention Comparison and Outcomes. It's a way to define our question. It's a way for us to think very clearly when we are asking practice-based issues or when we're about to conduct a systematic review or even when we want to go and search for the literature to answer a question, we can use PICO to help us refine what it is we're interested in learning about. So who is the population we really want to know something about? What are the interventions that we want to know their effectiveness on? What are we comparing those interventions to? And then very specifically, what are the outcomes that we are looking for? So what you see in front of you here as well is the very top part of a summary statement that's been written for the Fitzpatrick-Lewis 2011 review. And what we have highlighted in red there is just the citation of the original review that this summary and new update are based on. So you can see highlighted in red there the original review by Wang. So the summary statements are documents that we produce here at Health Evidence to try to condense into 2 to 3 pages at most what the review is about, what the findings of the review are, as well as what the implications for policy and practice and public health are as a result of the review. We also give you it, you can see in the top right-hand corner, November 2011. We also date them, and then just more generally in terms of how important dates are. It's always important to know any of the work that we look at, any of the evidence that is used in decision making, that we know if it's current or not. So it would be important to see dates included in any of those types of documents. And then finally, what's just been highlighted in red, the review quality rating. We can see that this review received a score of 9, which is 9 out of it on a 10-point scale. It's a strong review, so the methods of this review are strong. And if you would like to know more about how we rated this review, you could you see the hyperlink with the word here, and you can just click on that, and you would be then taken in Health Evidence to see how we actually rated that review. Actually, sorry, David, can we just go back for a moment there? So I'm just taking you back for a second to just focus on what this review was on. So we know here is that this review was focused on our population was marginally housed or homeless individuals or families with or without substance abuse issues or mental health. The interventions included in this review are any interventions aimed at improving health or housing status, with being compared to usual care or no intervention. And the outcomes of particular focus for this review under physical health, mental health, including psychiatric symptoms and psychological or cognitive function, substance use, including alcohol, drugs, or tobacco, HIV risk behaviors, healthcare utilization, adherence to health care, and quality of life. So let's now move on in terms of what were the overall findings of this review. And our conclusions tell us that the provision of housing for homeless or marginally housed populations leads to increased housing stability, small but significant decreases in substance or alcohol use, longer durations of abstinence, reduced emergency department or psychiatric inpatient use, and improved quality of life. So when we looked at all of the outcomes presented in this paper, and it is quite a complex review, these were the overall conclusions that we made. In addition, adding case management and or day treatment services to housing provision for varying homeless populations led to improved housing stability, need for less substance abuse treatment, and improved antiretroviral adherence. Then we thought about, so what does this mean now for public health? What would public health decision makers want to think about considering doing as a result of these findings? And we summarize these to say public health programs should include and or support provision of housing with rent subsidy or for homeless people with mental illness, housing, preferably abstinent contingent for homeless people with substance abuse, individual counseling to reduce risk among homeless people with HIV/AIDS, weekly educational sessions for homeless or runaway youth, and the provision of housing and or moderate consistent case management for homeless people with HIV/AIDS. If I seem a little disjointed today, I just arrived home from the UK late last night, so it's actually dinner time now for me. So I'm just trying to get back onto Ontario time. So one more implication to discuss here as well that we found from the evidence that non-abstinent contingent housing with case management is not recommended for homeless people with concurrent disorders to decrease psychiatric symptoms and substance use, but is recommended to stabilize housing. So some very interesting findings emerging from this review in terms of some of these interventions leading to improved stability with housing, but in certain populations not necessarily having a significant impact on substance use or psychiatric symptoms. So I would just like to do another poll at this moment and ask you, what do you consider to be the most important outcomes highlighted in this summary statement? And I'm just going to take a moment to let you comment on that. And just while you are doing that, I have another question here that's asking about if there's any evidence regarding crime rates, and as well, by the same person, resulting savings estimated net cost. So that's being, and in this particular review, where we have, actually I forgot to tell everyone that we actually have a whole team here ready to work on this while we're doing the webinar. So I have a few people looking into that right now. I do not recall seeing anything specifically about that in this review, but I will come back to that in a few moments and address that after it's looked into. Thank you for the question. So what has emerged from the poll is improved quality of life was voted by the majority of you so far, about 26%, said that was the most important intervention, followed closely by the increased housing stability, which 23% of you said that was the most important outcome, followed by the reduced emergency department visit. Okay, so just moving on now, I just want to break down that. As I said, that was the summary as an overall conclusion based on the many, many findings that are inherent within this review. So I just want to move to the first one, which the outcome was looking at homeless people with mental illness was population. Excuse me. And for this particular outcome, there was only one study that was included in this review by Forchuk, done in 2008. And I think it's important as well to talk about definitions. And so the definition of homelessness that was used in this study is that patients being discharged from psychiatric wards to shelters and with no fixed address. So in terms of what we learned from what was found about the results of this study is that interventions for homeless people with mental illness, the evidence told us that the provision of discharge support, so that was assistance with finding housing and payment of first and last month's rent, led to significant improvements in housing status up to 6 months post-discharge compared to individuals receiving usual care, and that in this instance was a social work referral. And that was statistically significant at P is less than 0.001. And the implication for policy and practice that public health decision makers should consider the positive impact supportive housing and rental assistance has on housing status of those discharged from psychiatric care, but also keeping in mind that there's very limited evidence. So at this point, we have one study to base that upon from a randomized control trial. So at this point, feel that that is strong evidence to inform practice, but also think it's important to keep track of this area as new studies hopefully continue to emerge to see if we would change our thinking about that. So I would just like to come back now to the questions that were raised about crime rates and costs. So specifically related to homeless populations, there were currently no reviews in health evidence that address this outcome, but specifically in this review, was there anything in this review that addressed that? And so that was not a focus of this review. That was not included in this. And also difficult to find. It's difficult to find in the public health review literature much about costs. So I think this is an important point to keep raising, that while we have a few studies that have started to include cost estimates and cost savings and doing formal cost effectiveness analyses, we still have very little of this type of data available in the public health literature, and even fewer reviews that have been done that would include that or have that as a focus. Okay. So we were asked to display the graphic of the answer distribution. Sorry, I'm not sure if that was in relation to the answers for what you consider to be the most important outcomes from the study. So if you could just comment, David, if that's what you're referring to, or if it's a different graphic you're referring to. We have another comment that says, I would say that the most interesting part is that the article describes the conditions in which the intervention is contraindicated. Yes, and you're right, and I think that's something very important we need to be thinking about in public health as well, in terms of not only do we know if something works, but does our data and does our work help us to identify populations for which the intervention does not work or in fact may be harmful for. Okay, so just moving on there in terms of now looking at populations where it's homeless people with substance abuse issues. And here we have a number of studies that were included that provided data on for this population, and homelessness being defined as chronically homeless list of individuals with high local crisis services utilization patterns. Chronic homelessness was not further defined. For the list of other studies, the definition used was lacking a fixed overnight residence, including shelters or temporary accommodations, or were at immediate risk of being homeless. So our findings there is that housing plus on-site case management minimally decreased the risk of alcohol consumption up to 12 months. And we see there a relative risk of 0.98 and a 95% confidence interval of 0.96 to 0.99. So I would just ask here again, so all of you know I'm a researcher, so I always have to be asking you questions. So a polling question of, are you familiar with relative risk? Is that term familiar to you? I'll just let you respond, and then we'll talk a bit more about what these findings mean. So the data is just coming up here, and of the initial results there, it seems like the majority of you are indicating yes, you do know what a relative risk is. Very large percentage. Right now it's 47% versus 14%, although a number have not answered. So this is really wonderful to see. So many of you who are aware of that. So just briefly, let's look at these results. So our relative risk of 0.98, this tells us that those who received housing plus on-site case management were 2% less likely to be consuming alcohol 12 months later. So a 2% risk in alcohol consumption compared to those who were not receiving the housing plus on-site case management. But that's only part of the picture. It's really important now for us to be thinking about the confidence interval. So the confidence interval tells us what the whole story is, which here ranges from 0.96 to 0.99. So if we use the same strategy for interpreting that as we did for the relative risk, we can see that the true range values from 4% less likely to be consuming alcohol to 1% less likely to be consuming alcohol at 12 months. So if we think, if we have here in front of us now, what is the definition of a relative risk? That's the ratio of the risk of an event among an exposed population, that being the intervention group, to the risk among the unexposed. So in this particular instance, the outcome is measured as a yes or a no. So when we only have two options for our outcome, and we would call that a dichotomous outcome, usually, yes or no, then we can actually do what's called a relative risk, or sometimes we might do an odds ratio as well. In this instance, no difference between the intervention group and the control group would be 1.0. And whether or not you are less than 1 or higher than 1, and whether or not that's a good or a bad thing is really dependent on what the outcome is. So in this case, risk for alcohol consumption, if our intervention is working, it would mean that our number is below 1. So the more below 1 our relative risk is, then the more effective our intervention is. The closer our relative risk is to 1, then the smaller the impact of our intervention. So in this case, we see that the relative risk is 0.98. So it is very close to 1. It's a 2% less risk of alcohol consumption. However, we won't argue that for today. I would leave that for all of you who work in social determinants of health to think about, is a 2% reduction in risk of alcohol consumption a big enough impact to warrant the type of intervention? So housing plus on-site case management. If what we wanted, if our outcome, what we wanted was for people to be doing more of it, so for example, whether or not people were more physically active after being exposed to a physical activity intervention, we would want the relative risk to be above 1. So the higher that number was above 1, then again, the more impact our intervention has. So that's how we need to think about understanding our relative risk. But again, now here when we look at that 95% confidence interval, we know that if we were to run this study 100 times, the results that we would get those 100 times would range from a 4% difference, the 0.96, so 4% less risk of alcohol consumption at 12 months, to a 1% less risk of alcohol consumption at 12 months. So as a decision maker, these are all of the pieces of information around impact that you would need in order to think about what to do with your programming. So that the housing plus on-site case management is associated with somewhere between a 4% risk, a 4% less risk in consumption to as little as a 1% risk. And then you use other forms of information, how big of an issue is this in your community, the resources to address now what your thinking would be on the benefits of this particular intervention. So I have a comment here by Diane. Could this mean that people may be drinking less at each drinking event? Also knowing impact for longer than a year, it would be helpful. So if I just address the latter part of that question, yes, you're right. I think knowing whether or not the impact of this intervention is maintained longer than 12 months is definitely something that needs to be happening. In this particular study, the outcome was 12 months, and I think what we need to keep on urging through our research funders here in Canada, as well as our researchers, is that we need even longer term follow-up than that. So definitely, I think we can only work with in this study what is provided, which at the longest point was 12 months, but certainly recognize that a longer outcome is also beneficial to know about. Here is, for the first part, which is, could it be that people are drinking less at each event? I don't think that's the way to interpret this, because this is talking about risk of alcohol consumption measured at was there alcohol consumption or not, yes or no, up to 12 months. So my interpretation, or our interpretation of this evidence, is that the risk for any alcohol consumption at 12 months was 2% less in those who had the housing plus on-site case management and compared to those who didn't. So I think it's more of drinking versus not drinking is the way this outcome has been defined in this study. Thank you for the question. Okay, so just moving on here, in terms of thinking about some more evidence that emerged from these studies, is that behavioral day treatment plus abstinence, contingent housing, and therapy, so shortened to be DT+, This increased the proportion of days abstinent at 2 months, which the data showed 71 versus 41%, as well as at 6 months, 41% versus 15% in comparison to day treatment alone. And furthermore, that relapse was lower in the DT plus group in comparison to the DT only group, and that was at 55% versus 81%. And then a few more, so a little bit more evidence as well is that abstinence contingent housing increased the mean consecutive weeks of abstinence to 7.32 weeks versus the no housing group, which had 5.28 weeks. So between abstinent contingent housing and no housing, there was a statistically significant difference in the number of consecutive weeks of abstinence. And then when that was compared to the non-abstinent contingent housing, there was also a statistically significant difference there between abstinent contingent housing and the non-abstinent contingent housing. And for all three groups, the number of days housed increased significantly, and that was significant at 0.001. So again, what does all of this mean in terms of what we do in public health practice? The suggestion being that public health decision makers should promote and support the provision of housing, preferably abstinence contingent with on-site case management to reduce substance use among homeless people with substance abuse issues. Day treatment, so the DT plus can also be used to increase days abstinent and also reduce relapse among homeless people with substance abuse issues. So now let's take a look at interventions with no impact for homeless people with substance abuse issues. So while there were some positive impacts for this population, it was also noted that there were some outcomes for which no impact was seen, and that was on the number of days housed in those receiving the DT plus compared to those receiving day treatment only, or in the number of weeks of abstinence from the non-abstinent contingent housing compared to those with no housing. So implications for practice and policy here is that public health should not promote or use DT plus if the sole purpose is to increase the number of days housed. So again, it's very complex here in terms of these interventions working sometimes and for certain outcomes for certain populations, but not consistently throughout. So we have another comment of yes versus no doesn't capture harm reduction. And so your point's well taken. Let me just reorient us back to these authors are summarizing the results of this particular study or these studies that were included in this review. And those were the ones that were available at the time that this review was conducted. So it's not that us as the summarizers of the evidence or the authors of the summary itself are they're only able to report on what is in those studies, and that is how that was defined in those studies. So I think the issue around harm reduction, while still needs to be raised and addressed, were not studies that were included in this review, and so we can't comment on them at this time. Okay, so there's another comment here that says, what were the on-site management used? So, sorry, I'm just thinking here is some more description of what the on-site case management was, and so I just have that being looked into right now, and I'll get back to you with the answer to that question. So we're now going to change the focus of the population that was being looked at, and for these particular sets of outcomes, the population were homeless people with concurrent disorders. And as we can see here, there were a number of studies that were included that provided data on this outcome. And the definition of homelessness that was used is that they had spent 15 out of the last 30 days on the street, not including shelters, and experienced periods of housing instability, although this was not defined further, within the last 6 months. So what did the evidence say here? Study participants given independent apartments without requirement of abstinence or psychiatric care spent 66% fewer days homeless, and that was statistically significant at 0.001, and had less need for substance abuse treatment at 36 months, so 36 months afterwards, compared to participants receiving outreach or drop-in services plus group living, and that was also statistically significant at 0.05. The independent living group, however, utilized healthcare services slightly more at 48 months post-intervention. Again, statistically significant at 0.05. So the implications for practice and policy. Public health decision makers may advocate non-abstinence contingent independent housing as a way to improve housing stability and decrease need for substance abuse treatment for homeless individuals with concurrent disorders, while acknowledging again that these particular findings are only related to one study, one randomized controlled trial. So I should have pointed that out at the beginning, but these are the findings of the one RCT out of that list I just showed you of studies reporting on this population. So again, good quality study. These are some findings. However, it's a limited body of evidence at this point, and we need to keep looking to see if anything changes as new knowledge emerges. In terms of, we also found that, however, that there were some outcomes for which no impact was observed, and we found that there was no difference between groups in psychiatric symptoms and substance use. And so implications there that if the primary goal is to reduce substance use or improve psychiatric symptoms, then non-abstinent contingent housing should not be used to improve psychiatric symptoms, decrease substance use rates, or decrease healthcare utilization. So again here, that challenge being of what are the outcomes that are of primary concern, and sometimes having different suggestions on what to do depending on what the main purpose of the outcome is trying to achieve. So I just want to go back now to address what the case management and what we know. So I'm just reading now directly from the review what was included in the particular study that addressed this. And it's talking about a program that's called Housing First, and it provided housing with on-site case management that encouraged participants to set goals related to substance use and other aspects of their lives. And that's all that's included, actually, in this write-up, in this review. And what would likely be required now, as is the case many times with systematic reviews, is that one would now need to go and find the primary study that's reporting on this, likely access that one to, and hopefully what would be included in that publication is a better description of the case management. And if not, and I always encourage this for everyone, would be to then contact the primary author. As an author myself, you're always happy to hear from people who are interested in one, reading your studies, and two, wanting to know more. So if that wasn't in the actual publication about this study, then certainly contacting the primary author. Primary author contact information is usually provided with every published study to learn more about what case management was in that particular case. So thank you very much for that question. So now thinking about, sorry, if we can just back up there for a second so I can remind myself of where I was. Sorry, can we go back one more, Diva? Thank you. So here we were just talking about interpreting the evidence for interventions for homeless people with concurrent disorders. So found here that there was some improvements in housing stability. And if we just move forward now, then we talked about that there was no difference on the psychiatric and substance use symptoms. And now if we just move forward again, so now we're just actually changing gears again here, and we're looking at homeless people who have HIV or were just recently diagnosed with HIV. And we see here that we have a number of different definitions that were provided in these studies. So just briefly, homelessness definitions were HIV-positive individuals living in a number of different housing contexts, either having one's own place to live, being unstably housed, meaning staying temporarily with others or living in a transitional setting and had not been homeless, or being homeless for equal to or greater than one night, for example, sleeping in shelters or locations not suitable for human habitation in the past 90 days. Other definitions were HIV-positive, marginally housed individuals, including reports of currently being homeless, living in a shelter or welfare hotel, or having lived in another condition in 12 months prior to the assessment or being included in the study. Homeless positive and homeless and marginally, HIV-positive, homeless and marginally housed individuals. Homeless was defined as greater to or equal to one night on the street or in shelter in the last quarter, whereas marginally housed was defined as greater than or equal to 90% of nights in single-room occupancy dwelling in the past quarter with no nights spent on the street or in a shelter. And finally, that cases were defined as homeless if medical records documented individuals were homeless, or if addresses listed in chart for shelters, healthcare clinics, or a general delivery address not connected to an address. So if we think about, if we turn to what the evidence is here, we see that rental assistance plus case management improved self-reported physical and mental health and housing status. 88% in the intervention group were housed at 18 months versus 51% with no intervention, and that was statistically significant at 0.001. Additional data indicated that 3 individual counseling modules, so 5 90-minute sessions, led to significant decreases in a number of outcomes. Those included number of days alcohol, marijuana use, and we see that difference there, statistically significant at 0.002. The next outcome, number of risky sexual acts, we see a change from 5.03 to 1.75, also statistically significant. And number of days of hard drug use, we see a change there from 27.76 to 24, and that was also statistically significant. This is all in comparison, in comparison to no intervention. Additional evidence also indicates that moderate case management improved antiretroviral adherence, and that was statistically significant versus versus none or minimal case management. And consistent and moderate case management led to a 50% improvement in CD4 cell count. And then finally, importantly, the risk of death was 20% higher for those not receiving supportive housing post-HIV diagnosis. So we see here relative hazard, the 1.20, and that 95% confidence interval ranging from 1.03 to 1.41. So very similar. Here we interpret this the same way we talked about the relative risk a few moments ago. So the 1.2 turns into a 20% higher risk of death, and that the true story, so the real range in the population would range from a 3% higher risk to a 41% higher risk of death in those not receiving supportive housing following an HIV diagnosis. This is homeless people following an HIV diagnosis. So implications, again, for practice is public health should support housing provision programs, preferably with moderate to consistent case management, to improve the health and housing status of homeless people with HIV and to reduce HIV risk behaviors and risk of death. Decision makers should advocate for case management support for homeless people with HIV to promote adherence to antiretroviral therapy and also as a way to improve the CD4 cell count. Outcomes for which no impact was observed. So no impact was observed on multiple individual counseling sessions compared to no intervention on abstinence or provision of rental assistance with case management on number of sexual partners, condom use, or sex trading. So implications for practice are that public health should not rely on multiple individual counseling sessions to achieve substance use abstinence. Public health should not use rental subsidy with case management to impact the number of sexual partners, condom use, or sex trading. So the last major area for the outcomes of the population were homeless or runaway youth. And again, we see here a number of studies that provided outcome data for this population. And they defined homelessness as spent 15 out of the last 30 days on the street, not including shelters, and experienced periods of housing instability within the last 6 months, although housing instability was not defined further. So what was the evidence here? It was found that 12 weekly sessions covering life skills and psychiatric issues plus HIV/AIDS education led to a greater reduction in substance use from baseline, 37%, compared with usual care, which was found to be 17%, and that this was statistically significant at 0.001. Implications for practice: public health decision makers should consider weekly education sessions covering life skills, mental health, and HIV/AIDS education to reduce substance use among homeless youth, while acknowledging, again, that this is actually data emerging from one randomized controlled trial. So again, good data to inform what we're doing at this point, keeping a watchful eye out for new emerging studies in the short and long term to see if our knowledge changes of what's happening, and therefore we might consider if we need to be doing something different. So here they all are again, the considerations for public health practice. So again, just to recap, that the provision of housing for homeless or marginally housed populations leads to increased housing stability, small but significant decreases in substance and alcohol use, longer durations of abstinence, reduced emergency department or psychiatric inpatient use, and improved quality of life. Adding case management and or day treatment services to housing provision for varying homeless populations leads to improved housing stability, less need for substance abuse treatment in the long term, and improved antiretroviral adherence. So overall, the public health programs, implications to think about are the provision of housing with rent subsidy for homeless people with mental illness, housing, preferably abstinent contingent, for homeless people with substance abuse, individual counseling to reduce risk among homeless people with HIV/AIDS, and weekly educational sessions for homeless or runaway youth. The provision of housing and or moderate consistent case management for homeless people with HIV/AIDS. Non-abstinent contingent housing with case management is not recommended for homeless people with concurrent disorders to decrease psychiatric symptoms and substance use, but is recommended if the goal is to achieve stable housing. So I just would like to check in with you right now and ask you a couple of additional questions. So the first one is, did you find this data on this review helpful? As a yes, no. And the second one, were these findings new to you today? So I'll just give you a few moments to respond to that. So the data is just coming up now. And for the first question, did you find the data in this review helpful? And a very large majority of you are saying yes. So about 50% of you that have commented have said yes, 11% have said no. And then were these findings new to you today? 42% of you have responded, oh, that's just gone up to 45% have responded yes, and 18% have responded no. And both of those actually make me very happy for very different reasons. So if these are new to you today, we're very glad that you were able to join us to hear this, what is new evidence for you. For those of you that are already aware of them, it's actually great that you are already knowledgeable of what the evidence is that's out there currently on this issue. So also an important factor in terms of being aware of what the evidence is. So I have an additional question here from Dave that asks, are data such as those just shown sufficient to influence public policy? And I think that that's a great question, and I think I'm not sure I'm the person to answer that. I guess that would be the question I would have for all of you in terms of is the impact compelling enough? And I guess what I would add to that is it's just one part of the evidence that one would use to inform either public health programs, other programs, and public health is certainly not the only health sector involved in providing interventions to these populations, but also what other types of knowledge would one use of their population, of resources, of client preferences to inform what those policy and programs are. And I don't know if there's an opportunity for other people to respond to Dave's comment there. What do others think that are with us today? So just maybe while you're thinking about that and considering responding to Dave, and I might ask you to comment, Dave, what you think about those, whether or not these data are sufficient to influence policy. But I see that there's another comment here from Carolyn, or a question. What process does health evidence use to create the general implications? Thank you. That's a great question to ask there. So we actually go through the process of we pull out the evidence on all of the points and synthesize those into very tight statements about the evidence. And then we focus on what would be reasonable actions for public health to consider taking based on what that evidence says. So I always think about trying to put us in the position of a manager in public health so that we can try to word these statements in as useful a way as possible to think about what would be useful for them to see. And so we then consider, based on the confidence intervals and based on what was found, so was the outcome, is the intervention effective for a certain population, sometimes in which settings, and so we consider all of those options when we're writing the implications. And those get reworked and revised a number of times. What we've also done in the past, we haven't done this for this summary for today, but what we also do, and through our interaction with public health decision makers, is get feedback on these from those that work in public health. And certainly if you have comments or feedback or suggestions, tweaks that can be made to this summary statement in particular, or other ones on health evidence, we're certainly happy to see those. So another aspect that we could do to move this forward, to continue to move forward the development of summary statements, would be to send the review and the summary statement out to a group of public health decision makers and ask them for their feedback and suggested changes on that summary statement. So we have a response here, I believe, from Marcelin, I'll say. I'm not sure. I hope I said that right. The issue is not to know if housing will help improve health, but how public health could efficiently mobilize other sector partners. We also need evidence for this, and yes, I would agree. And it's actually one of the challenges of doing rapid reviews and systematic reviews, in that, you know, in order to be able to answer a question well, we need to actually refine it so that we can focus on answering a particular question. And what it doesn't allow us to do is to then answer usually multiple questions. And so I would suspect that an additional review that specifically answers this question of how to efficiently mobilize other sectors could be the focus of a completely different review. And thinking about what would also be very interesting, just off the top of my head, as I start to envision what a review like that would look like, is likely a very different type of research design in terms of how one would go about evaluating what are effective ways to mobilize other sector partners. But yes, I agree, very important issue. So Dave, thank you for providing an answer now. It depends on principles being held and how closely they are held in the face of evidence. And yeah, I agree, and I actually would believe that there's no one right answer for everybody in terms of the different agencies that everyone works in across the country, province to province, and territories. Urban versus rural, there would be many, many factors, and I think that the same evidence could inform and support very different types of decisions that could be made, and of course how it's valued in comparison to other evidence, or how it holds up, is also important. Okay, so did we get any final numbers on the two polling questions? So we're changing screens. So it's really great to see 55% of you found the data helpful, and for 47% of you this was new information. So I just want to, I think we've already started this discussion, but really thinking about what is the most important thing you learned today. This question's been posted in the chat window, and it would be wonderful to hear your responses to that. We can continue to talk about that now as well. We're following this up with a live chat on Monday, and we will also post any comments that you include in the chat window today during that live post on Monday. So just while giving you a moment to see if anyone is responding to that, just to give you a little bit of information about the discussion forum. You know, so this webinar is really just, we hope, step one. And it's really to promote and debate and dialogue what these findings really mean, what their implications really should be at different levels of program planning and policy making. And so we want to provide the opportunity to continue discussing these issues beyond today. And would I invite you to join us on Monday from at 1 o'clock to keep doing that, and you would access that through the www.healthevidence.ca forum. You just need to log in with your Health Evidence username and password if you're a registered user already. If you aren't, we would really encourage you to do so. It's a very, very simple process. We just ask for a few simple details, demographics really about who you are. An added benefit to being a registered member of Health Evidence is that when we do our quarterly updates of the site, then you will receive links to any review newly added to the website that is directly relevant to the areas that you've told us you're interested in learning more about. So we hope that you'll be able to join us on Monday at that time. And then finally, this is a CIHR grant, and as always with everything that we do here at Health Evidence, we're always striving to provide useful services for public health decision makers and others across the country. And so we would like to ask you to take a few minutes to do the evaluation. You'll be receiving in your email shortly the link to complete this survey. It's very, very short. It is going to take you 5 minutes. If you have a lot to say, it might take you 10 minutes, but we're really just trying to get a sense of whether or not webinars are a good way to continue proceeding, what impact they might have, and ask you to be on the lookout for an email from Jennifer McCougan to be sending you that email shortly and to complete that online. And that continues to help us to evaluate and tweak what we do with respect to webinars. Okay, well, I think that's going to be it today, unless there's any last comments from anyone. And we see from Susan, the specific findings about interventions with homeless people were interesting and new to me. Thank you, Susan. It's great to have you joining us today. So I don't think that anything else has been posted to the chat now in terms of what was the most important thing you learned about today. I'd like to ask you to reflect on that, and I'd be very interested in discussing that further on Monday. So look at that. We've saved, you found an extra 10 minutes in the day. I'd like to thank all of you for joining us today. We have more webinars in the new year. We have 2 additional topics. And of course, I know right now that I'm trying to say them off the top of my head. They're going to lose. One's child and family health and chronic disease prevention. So we have webinars happening in January, in February, 2 in February. Sorry, I'm just getting this. This is the challenges of doing some of this in real time. And now I know what it's like to be, if I was ever a radio broadcaster. Those guys have a hard job. So anyway, stay tuned. We will be sending out additional information. Some of you may have already signed up for those. And actually, as long as we are hearing that these webinars are useful, our intent is to start offering monthly webinars through 2012. And we hope to have you join us again. So thanks very much, everyone, and enjoy the rest of your day. Bye-bye.